Greetings from National Academy of Medical Sciences, India. NAMS has been recognized by the Government of India as a nodal agency for promoting the continuing medical education for medical and biomedical professionals. National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia and workshops in medical and biomedical professionals. NAMS is pleased to announce the launching of a joint NAIIMS NAMS Navigate CME program from 1st September 2023 for postgraduate students in all the NAIIMS and other eminent institutes of national importance from Andhra Pradesh, Arunachal Pradesh, Assam, Bihar, Chhattisgarh, Goa, Gujarat, Haryana, Himachal Pradesh, Jammu and Kashmir, Jharkhand, Karnataka, Kerala, Madhya Pradesh, Maharashtra, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Punjab, Rajasthan, Sikkim, Tamil Nadu, Telangana, Tripura, Uttar Pradesh and Uttarakhand of the country. The program is being conducted online on the first Friday of every month from 3 p.m. to 5 p.m. The NAIIMS NAMS CME focuses on the topics which are of common interest for the postgraduates across all specialties. The aim of the National Virtual Postgraduate Medical CME is to help them to be more proficient in their profession. Each session will cover 2 topics. Each topic will be of 1 hour duration, which includes 45 minutes for presentation by speaker, 15 minutes for questions and answers. Thank you for your kind support.
Hello and good afternoon, everyone. Welcome to the next session of NAMS-AIIMS Navigate Medical CME program. This time we are with a very important topic, that is peripheral neuropathy, since we know that in India, in almost every household, we can see the patients suffering with the symptoms of peripheral neuropathy. This is one of the most underdiagnosed, I would say, disorder. And also, since diabetes is increasing day by day in our country, and it's also the leading cause of peripheral neuropathy. Other than that, we are also the country of various infections, toxins. So we are at a risk of peripheral neuropathy. And today with us, we have very eminent speaker, Dr. Manoj Goyal. So he will be teaching us and guiding us with the case of peripheral neuropathy. So just to continue session, I would request Professor Ajay Kumar Sood sir. He is the Deputy Secretary of National Academy of Medical Sciences for the welcome address. Over to you, sir.
Thank you, Dr. Jaswant. In fact, on behalf of the National Academy of Medical Sciences, it is my great privilege and honor to welcome the distinguished speaker for this year's session, Dr. Manoj Goyal sir. Sir is a senior faculty member from PGI Chandigarh and lot of experience in this area. And I'm sure that the practical tip which sir will give to all of us, especially to our PG student, will be of great help. Thank you so much for being with us. And I'm sure your contribution as an academician for PG student will be very, very useful. I also take this opportunity to welcome all our faculty members who have joined us from various medical institutions and NAIIMS. And once again, I want to make an appeal that this is your own program and you can give us suggestions for the topics which you want us to take in future. And you can also volunteer to take a session as faculty resource person. For the PG student, again, this is a unique opportunity. If you have any question or queries, you can just put your question in the chat box. And at the end of the session, sir will be happy to answer those questions and queries. So with these words, once again, I welcome you all. And I look forward for a very interesting and productive session. Over to you, Dr. Jaswant.
Sir, thank you, sir. Now I request Mr. Ravizi, the head of technical team, for the message from Professor Digambar Behera, the President of National Academy of Medical Sciences. Please.
My dear young colleagues, faculty, and officials of the National Academy of Medical Sciences, a very good afternoon to all of you. With immense pleasure, I invite you all to this program. National Academy of Medical Sciences, that is NAMS India, it was established on the 21st April of 1961 with the objectives of promoting the growth of medical sciences. It was inaugurated at New Delhi on 19th December 1961 by Pandit Jawaharlal Nehru, the first Prime Minister of India. The NAMS fosters and utilizes the academic excellence of health professionals in the country as its resource to promote excellence in medical education and skill development in the field of medicine and allied sciences. The Government of India has recognized the Academy as a nodal agency for promoting continuing medical education for medical and allied health professionals and is advising the Government of India on several matters of national health policy and planning. The best in the field of medicine are part of this umbrella organization, and who is who of medical science guide the NAMS. The National Academy of Medical Sciences encourages and sponsors nationwide CME programs, symposia, and workshops in basic sciences and applied clinical disciplines. The aim of the National Virtual Postgraduate Medical CME is to facilitate the postgraduate students and young faculty members to increase their knowledge in the medical subjects, to navigate them to be more proficient in their profession and pass their NEET and PG examination to become better doctors, eminent biomedical scientists, teachers, and researchers. As a part of this responsibility, NAMS, in collaboration with the AIIMS New Delhi and 16 other AIIMS-like institutions of the country, has initiated this navigation program in the form of dialectical lectures and discussions. The program is regularly held every first Friday of the month at 3 p.m. The best and useful topics are carefully chosen, and the best teachers from various AIIMS are picked up to prepare and give these lectures. I am sure you all will enjoy these talks and will like them and found them useful in your future lives. Thank you.
Thank you. Thank you. So next, I would request for a message from Professor M. Srinivas, Director, All India Institute of Medical Sciences, New Delhi.
Namaskar. At the outset, I congratulate the team behind the NAMS-AIIMS Navigate CME program. Providing quality of education to our postgraduate students is one of the prime responsibilities of AIIMS. I know that our able faculty is leaving no stone unturned in achieving this mission. However, there always remains a scope for improvement. Through this unique initiative, there is an opportunity for our postgraduate students to learn from the experts in their field. This learning will go beyond the boundaries of department where our postgraduate students are working and will also bring in more flavor in their knowledge and at the same time ensure dissemination of uniform, high quality content all across the nation. Postgraduate students also form our primary workforce for providing patient care. This indeed is an important component of their training. We are aware that our postgraduate students devote a large component of their time for the patient care services and thus they have less time for self-study by the end of the day. The timing of this activity is therefore very carefully chosen. The sessions will be held late in the afternoon so that the beneficiaries do not have to make any extra effort for attending them. This by itself exudes the philosophy of a true teacher, a mentor that will handhold the children through the process of their active learning. As the sessions are online, which by its very design is a non-synchronous platform, it may seem that the delivery of the content will be one-sided, but enough measures have been planned and they are in place to make the activity as interactive as possible. The topic of the session will be shared with the students well in advance. This will allow them enough time to explore the subject and be better prepared to absorb the content. This design, therefore, also matches the concept and principles of adult learning. The program not only will help our postgraduate students in being better prepared for their examinations, but also will equip them with sufficient knowledge, understanding, and approach to be a better professional in their field. I wish this program all success. Thank you.
Thank you. For now, it's the time to introduce the speaker of the day, Dr. Manoj Kumar Goyal. As sir mentioned, sir is the senior faculty member in the Department of Neurology at PGIMER Chandigarh. Sir has special interest in neuromuscular and neuroinfection. He has numerous publications and book chapters in his name and an impressive H factor, H index of 23. And he has been the best outgoing student in the neurology from NAMS-AIIMS, Bangalore, and also been awarded during a COVID pandemic. So with this brief introduction, without wasting much time, now I welcome Dr. Manoj Goyal, sir, for the session. Sir, over to you.
Thank you. I'm just share screen, sir. Thanks, sir. Hope I am audible, sir.
Yes, sir.
Yes, sir. You are audible and the slides are visible.
Thanks a lot, sir.
Thank you,
Thanks
sir.
a lot for kind introduction. Just one disclosure before I start presentation for today. I have taken quite a number of slides from, the person from whom I learned neurology, Professor Arun Vitali, my rubber teacher. And I have taken permission at that time only when I finished my degree in 2007. That's why whenever I need, I will be using your slides. So, see, this topic is, though it looks, it's a difficult topic. And we will be going through our journey in next 45 minutes from very basics and try to cover as much of it as possible. So I am not going to go through this slide, but basically what we will be highlighting is how to approach a patient of neuropathy, how to evaluate with a clear-cut aim in mind that something can be done for every patient. So we start with basics, that is anatomy of a nerve. See, all of us know that so a peripheral nerve, the main function of a peripheral nerve is to carry sensations, pain, touch, temperature, proprioception, as well as visceral sensations to CNS via sensory nerves. And at the same time, the motor fibers in the nerve bring impulses from CNS to effector organs, that is muscles and glands, right? And at the same time, through these glands, it subserves autonomic functions also. So this is the basic structure of a neuron. So as we know, everything is being produced in the cell body. This cell body is responsible for production of proteins, mitochondria, other things, and they are transported through axons to the axon terminals, right? So cell body produces things, they are transported to the axon terminal, and this anterograde transport is very, very important for function of the distal axon. At the same time, cell body also, this distal axons also send signals to the cell body via a retrograde transport, which is essential for its functioning, a normal function. So clear, both anterograde transport is taking place as well as retrograde transport is taking place. So any damage to the cell body is going to affect axon. Any disruption here in between to the axon is going to disrupt axon terminals, and any interruption here is also going to block signals from axon terminal to cell body, thereby resulting in damage to the cell body. So this is the basic structure of a nerve. I think you all know. Just briefly, just because this is going to be very important. So every nerve has both sensory as well as motor fibers. Most of the peripheral nerves are mixed. The sensory fibers carry sensory impulses from peripheral organs, say fingers, toes, everywhere from the body. And their cell body for large fibers lie in dorsal root ganglion, at least for large fibers. They relay in the spinal cord from where a motor anterior horn cell, that is motor neuron, sends signals via motor nerve fibers to the effector organs. Most of the time muscles, as far as spinal cord is concerned, muscles. Okay. So we have both sensory as well as motor fibers in the nerve. The cell body is lying in dorsal root ganglia and in anterior horn cells. So just a brief review of normal basics of the nerve fibers. We have, all of you are aware that we have many different kind of nerve fibers. There are large nerve fibers as well as small nerve fibers. The largest in the body are A alpha. They are myelinated and carry proprioception and somatomotor sensation. See, up to A alpha, B, gamma, and to some extent delta are myelinated fibers. Their diameters are large. Their main function is proprioception, somatic motor, touch, pressure, and motor to the muscle spindle. While there are other fibers which are small and which are unmyelinated fibers. They carry pain, temperature, and autonomic function. So primarily two type of fibers: one myelinated, which carry proprioception, somatic motor, deep tendon reflexes through muscle spindles, and unmyelinated, which carry pain, temperature, and postganglionic autonomic fibers. Clear? So what are the basic pathologies in nerve fiber? So this is an important slide because whatsoever I will be discussing will be based on next 4 pathologies. So the first one, everybody has heard about Wallerian degeneration. That is, we cut a axon here, and right. If we cut a axon here, as we already discussed, the anterograde transport will be impaired. The resultant will be that the axon distal to the cut will be damaged. But we call it as axonotomesis or neuropraxia or neurotomesis, depending on the degree of nerves. So basic concept is anterograde transport is gone, so distal axon get destroyed. This classically we see whenever a patient comes to us with, Saturday night palsy, or there is a trauma to the nerve, or roadside accident. So this is what is the concept of Wallerian degeneration. We probably are not going to discuss it much more. Then comes the concept of axonal degeneration. We already discussed that this sensory root ganglion, cell body lying in the sensory root ganglion, and for motor fiber, cell body lie in the motor. So what happens if there is some kind of insult to this region or this region or this region? See, the distal most part is receiving less nutrition from here. Okay, so the proximal fibers are going to get very good nutrition. It is just a matter of distance. How much distance and nutrients have to travel? While the distal most axon is getting least amount of nutrition. So in most of neuropathies, metabolic, toxic, vascular, or hereditary neuropathies, this part is especially vulnerable. And it is the distal axon which gets damaged. This is the second main type of pathology, what we call as axonopathy or axonal degeneration, right? So the first one was Wallerian degeneration and second axonal degeneration. Now this axonal degeneration, as I told, in metabolic, toxins, including diabetes, metabolic including diabetes, is responsible for classic glove and stocking neuropathy, which we all equate in clinical practice. Glove and stocking neuropathy. Okay, the symptoms starting in feet, by the time they reach mid-calf, symptoms will start happening in hands. By the time they reach mid-thigh, there will be a tent-like area of sensory loss over the abdomen. The third pathology is demyelination. So here it was primary damage to the axon. Now here the primary damage is to the myelin sheath. We all know that the large fibers are surrounded by myelin sheath provided to them by Schwann cells. Okay, so in demyelination, it is usually due to damage to myelin sheath by a toxin, and it can happen anywhere. It can happen distally, it can happen proximally, more so proximally because blood-nerve barrier is not that well defined at this side. So this is what we classically see segmental demyelination in inflammatory demyelinating neuropathy like Guillain-Barré syndrome and chronic inflammatory demyelinating neuropathy. Now, in contrast to axonal damage, where the maximum of damage was distally, here damage is more of both proximally and distally. And accordingly, we can get proximal symptoms, proximal weakness or distal weakness. So next pathology is segmental demyelination. And the final is the damage to the cell body itself. It can be to the sensory neuron or it can be to the motor neuron. So if there is damage to the sensory neuron, both proximal as well as their projections in the CNS, as well as distal, axon, as well, myelin is going to get lost. Similarly, if there is damage to the motor neuron, all these motor fibers will be lost. This is usually autoimmune, or like we see in paraneoplastic syndrome such as anti-WHO antibody related sensory ganglionopathies. And here the patient is much more disabled and the chances of recovery are less because cell body itself is destroyed. In axonal degeneration and segmental demyelination, cell body was intact. So there was chance of improvement. Here, cell body itself is destroyed, so chance of improvement are less and prognosis is poor. So the next question is, what are the clinical symptoms of peripheral neuropathy? I hope till now everybody has understood. So we just discussed Wallerian degeneration, axonal degeneration, segmental demyelination, and finally sensory neuronopathy. So all neuropathies present with almost the same sense of symptoms. That can be sensory, that can be motor, or that can be autonomic. But commonly we miss are autonomic symptoms of autonomic dysfunction. Sensory symptoms include can be both negative and positive. Negative symptoms are numbness, anesthesia, loss of pain and temperature. I cannot feel the sensation. I got an injury but never had a pain. And positive symptoms include paresthesia, burning pain, allodynia, whereby non-painful stimulus, a normal stimulus is received as painful, and ant crawling sensation. You all are aware of that. Motor symptoms again can be both negative, such as weakness, or positive, such as fasciculation. And autonomic dysfunction includes impotence, gastroparesis, patient only after taking small amount of meal, they feel their belly is full and they do not want to take meal in the evening, Horner syndrome, constipation, nocturnal diarrhea, postural hypotension, and feature siesta of lower motor neuron type of bladder. So these are the common symptoms of peripheral neuropathy. I am practically not, I understand that everybody knows how to differentiate between cord and peripheral nerve, so I am not touching that part. Still, just for the beginners, in cord you get a sensory level. Okay, if there is a damage in the thoracic cord, all these symptoms will be below that. But in neuropathy, you don't get that. So they will be more like graded in the feet, in the hands. Okay, proximally in the upper limbs, distally in the lower limb. So proximally in the lower limb, distal in the upper limb. So you don't get a level. The classic feature of cord lesions is a sensory or motor level, which we don't get here. Of course, deep tendon reflexes and other things do help us in differentiating between neuropathy versus myelopathy. So now, classification of peripheral nerve disorder. So this brief slide is mononeuropathy is just what we commonly see in clinical practice. One is just a single nerve involvement, plexus involvement, and then multiple nerve involvement, which can be symmetrical or multiple mononeuropathy or even polyradiculoneuropathy, as we see in Guillain-Barré syndrome. We just discuss these one by one. First, we discuss mononeuropathies, and we start with the case treatment. Okay. Now, see carefully and understand this patient. This is a 32-year-old lady who was apparently normal till 4 days back. She develops acute pain around shoulder region, which subsides in a say 24 to 48 hours, and then she notices that she cannot abduct her shoulder. On examination, there is weakness of right deltoid with a power of 1/5. Sorry, this is biceps. Bicep muscle is normal in power. Infraspinatus is normal. Deep tendon flexes are normal. There is no sensory loss except for doubtful hyperesthesia at the outer tip of shoulder. Deep tendon flexes are normal. So what is the diagnosis? Here I want to stress one thing. So history is equally important. Examination, everything is equally important, but it is primarily examination which gives us localization, and usually the etiological diagnosis is given by history. So on examination, you see there is weakness of right deltoid. Deep tendon flexes are normal. So now we have to localize that from where this can come. So for this, we need a brief knowledge of brachial plexus. See, these are the roots. Okay, C5, C6, C7, C8. We know after that trunks, division and all. Now, if we see C5 root, see how many muscles it is supplying. It is supplying long thoracic nerve to serratus anterior. It is giving fiber to upper trunk. It is giving fiber through lateral cord to muscocutaneous. Although median nerve is not dominantly supplied by it, but for nadir teres, all it is supplying to supraspinatus and infraspinatus. So if it is a root lesion, C5, we are not going to get weakness isolated of deltoid. We are going to get weakness of many other muscles in addition. Similarly, if there is a lesion of upper trunk, we are not going to get weakness only of deltoid. We are going to get many other muscles which are supplied by upper trunk, including biceps, deltoid, and muscles supplied by, including this suprascapular nerve. The only difference will be C5 supplies rhomboids, while this does not supply rhomboids. Clear? In index patient, we have weakness only of deltoid, no other muscle. So from where this can arise? This is likely arising from axillary nerve, which supplies only deltoid muscle. Okay. So once we have gone through localization, we are very sure we are dealing with a disease of the axillary nerve. And when we look at the history, which is likely going to give us the etiology, we are left with nothing else except brachial plexopathy, because this is the classic history of brachial plexopathy, wherein you get a classic pain for 1 or 2 days, followed by weakness of the index muscle. Okay, so this patient received steroids and improved fully. Another lady, 35-year-old, she underwent hysterectomy under spinal anesthesia. And upon recovery, she felt that she is not able to bear weight on left leg. Carefully note what were the weaknesses: left iliopsoas, left quadriceps, and there was in addition sensory loss on medial aspect of left leg from foot to ankle, and left knee jerk was sluggish. So 3-4 findings: left iliopsoas was weak, left quadriceps was weak, there was sensory loss on medial aspect of leg, and left knee jerk was sluggish. So what is the likely diagnosis? Again, we go to our anatomical knowledge. You see L3, this is the sensory supply. So L3, sensory supply of L3 root does not go to medial side of the leg, which is supplied by saphenous nerve. Saphenous nerve is a branch of femoral nerve. So just by doing a simple sensory examination, you are sure in my index patient, I am dealing with a femoral nerve injury and not a L3 root or plexus lesion. Similarly, if there is a L3 root lesion, if there is L3 root lesion, we are going to get weakness of other muscles also. Okay, we are going to get weakness of adductors of the thigh. We are going to get weakness of
You are connecting yours, huh?
we are going to get weakness of other muscles also.
Disconnect பண்ணிடுறோம்.
வீடியோ வரணும் சார், வீடியோ வேணும். திருப்புங்க சார், வீடியோ.
So in femoral, as we are having weakness only of iliopsoas and quadriceps, it is difficult to check other muscles, and we are getting sensory loss in the distribution of saphenous nerve. We are very sure here that our localization is at femoral nerve. And considering the history of hysterectomy, it is likely that it is due to abnormal position with stretch on the femoral nerve, which has likely led to femoral nerve palsy in the index patient. So based on our anatomical knowledge of nerves, we are able to diagnose whether we are dealing with a mononeuropathy, and if yes, what is the site of the limb. So, right? So at this point of time, for mononeuropathies, when you have to differentiate mononeuropathies from plexus or root lesion, remember a single root lesion will never paralyze a muscle. Like for example, a bicep muscle is supplied by C5, 6, and 7. The dominant supply is C5, but there is C6 and 7 also. So power is not going to be zero. On the other hand, if there is a lesion of musculocutaneous nerve, bicep muscle will be completely paralyzed. Okay. So plexus and nerve lesions can lead single muscle fully paralyzed. On the other hand, root lesions, if they involve single root, they are not going to paralyze the muscle fully. So this will help you in making a clinical decision at bedside, whether you want to image the nerve, whether you want to do nerve conduction studies, or whether you want to image the spine to rule out a root lesion. So now we move on to polyneuropathy. So we discussed about mononeuropathies. Okay, multiple mononeuropathies and polyneuropathies we discussed together. So we discuss these polyneuropathies under following headings: etiology, temporal profile, topography, type of fibers involved, pathology, and genetic. Just briefly about each one, and we see how we are able to reach at a final diagnosis. So all of you, I am sure, are aware there are numerous causes of polyneuropathy, the common one being metabolic, diabetes, nutritional, vitamin deficiencies, of course, infection, all of you, leprosy, continues to be an important cause of mononeuritis multiplexa in India. Genetic neuropathy, inflammation and demyelination, as we see in Guillain-Barré syndrome and chronic inflammatory demyelinating polyneuropathies. Vascular diseases, drugs, numerous cisplatin, vincristine, toxins, arsenic, all that, and poisons like OCP, along with compression like carpal tunnel syndrome. These are roughly the most of the causes. Of course, there are paraproteinemia, paraneoplastic, and all, but these are usually the main causes which cause neuropathies in our clinical practice. So how do we evaluate? So first is the etiology we discussed. The second most important thing is to determine the temporal profile, right? So on the basis of temporal profiles, neuropathies are classified into three types: acute, subacute, and chronic. There is a overlap between the three. Another thing which I want to highlight here is onset is not just that patient noticed symptom on one particular day. See, if a patient is vigilant, he is going to notice a symptom on one particular day. Onset itself is defined as from beginning to peak of the symptoms. Okay, so based on this, we decide what is the onset. If right, so if onset to peak is within 4 weeks, we call it as acute. If it is still progressing beyond 4 weeks, we call it as subacute. If it is still progressing beyond 8 weeks, we call it as chronic. And then there is another course called remitting and relapsing that I think all of you are aware. So what are the causes of acute neuropathies in clinical practice? There is a long list of causes. Even diabetes can present with acute polyradiculoneuropathy, but I skip these. For all practical purposes, acute neuropathies are Guillain-Barré syndrome and allied disorders. Mean the disorder which we take which we take into account while considering differential diagnosis of Guillain-Barré syndrome, include porphyria, botulinum, toxins such as arsenic, vasculitis, especially ANCA-associated. Charax-Strauss. Most of the time, in my experience, I have seen Charax-Strauss mimicking GBS. Of course, other connective tissue disorder, diphtheria, now very rare, and poisons such as with organophosphorus compounds. So these are the neuropathies which roughly present acutely with onset to peak being less than 4 weeks. Subacute polyneuropathies, practically all of them can present subacutely also. But the common one which we consider are vasculitis, toxins, drugs, subacute inflammatory demyelinic polyneuropathy with or without a monoclonal gammopathy, and paraneoplastic. Of course, porphyria can rarely present as a subacute neuropathy. Guillain-Barré differentiation between acute and subacute inflammatory demyelinic polyneuropathy is still a matter of debate. So these are the basic ones. Even leprosy has to be included in acute, in subacute, as well as in chronic. So these are the rough idea which neuropathies are going to present subacutely. And then for chronic, there is a whole long list. CIDPs, all metabolic, whether it is uremia related, whether it is liver failure related, whether it is diabetic, nutritional, whether it is vitamin B12 deficiency or thiamine deficiency or whatsoever, infections, inherited neuropathies. So all these are going to present with chronic neuropathy. And relapsing remitting, remember, CIDP, AIDP, we all know can present as relapsing remitting. Porphyria, we all know. Remember that toxin can also present as relapsing remitting neuropathies, especially when the exposure to the toxin is intermittent. Okay, and rarely this HIV neuropathies, related neuropathies can also, depending on the CD4 cell count, can also present as a remitting relapsing course. Vasculitis, toxic, hereditary neuropathy with liability for pressure pulses are understood that they are going to present as relapsing remitting neuropathy. So based on history, we can bit of think that, okay, I am dealing with one of these. Even for that matter, nutrition also can present with relapsing remitting illness. Next, so based on temporal profile, we decided as acute, subacute, and chronic. And now we move to the next one. That is topography of involvement. That is which muscles are being weak. That also helps us in differentiating between type of neuropathy and shorting our differential diagnosis. Now, this is I discussed in the Valerian degeneration. This usually occurs following trauma also, and here patient will present symptoms and signs confined to distribution of a single nerve. On the other hand, what happens in axonal degeneration, wherein we discussed already that it affects distal most part of the axon. This is the most common form of neuropathy in clinical practice, being seen in metabolic disorders like diabetes, toxins, vascular, hereditary neuropathy. The damage is distally. So what we are going to see here is classic glove and stocking pattern of weakness, right? So symptom will start in the toes, will move up. By the time they reach mid calf, you start having small weakness of the symptoms in the tip of the fingers, and by the time they reach mid thighs, you start They reach elbows in upper limbs and they tend to involve abdomen as well. The third pattern we discussed was demyelination. There also we highlighted this point that demyelination can occur anywhere. So accordingly, if the primary disorder is demyelination, we are dealing with a demyelinating neuropathy wherein the primary damage is to myelin sheath. We can have proximal weakness. Okay, we can have distal weakness, or we can have combination of them. Clear? As we now understand in AIDP and CIDP, we often get proximal weakness. In MADSAM, we get both distal as well as proximal weakness. In multiple motor neuropathy, we get commonly weakness much more in the distribution of individual nerves. And in distal acquired demyelinating sensory neuropathy, we get distal sensory symptoms. And the last one, where there is damage to the neuron. So if they are usually associated with damage either to the sensory neuron or to the motor neuron, depending on the cause. If there is damage to sensory neuron, but what is happening here? The entire nerve fiber is getting destroyed. So commonly we are asked a question, how to differentiate sensory ganglionopathy from demyelinating sensory neuropathy. Okay, this is also sensory fiber. Demyelination, there is demyelination happening, whereas in this, we are getting damage to the sensory neuron. So see here, whole of the nerve fiber is getting affected. So you are going to get proximal symptoms, sensory loss over the trunk, sensory loss over the face, sensory loss over large proximal parts. Then we think of sensory neuronopathy, usually either autoimmune or idiopathic or associated with paraneoplastic syndromes such as anti-Hu antibody. So that is with regard to topography of weakness. As we understood just, if there is axonal degeneration seen with metabolic toxins, vascular heredity, we are going to get glove and stocking neuropathy. If there is demyelination, you can get proximal weakness, you can get distal weakness, you can get both proximal and distal. With sensory neuronopathies, damage to the cell body, you are going to get both distal as well as severe proximal sensory loss. And the etiology that we discussed are different for all the three types, helping us to reach at a close differential diagnosis. So I just now simplify it. So if you get cranial involvement, see, in axonal degeneration, we read that distalmost part of the nerve is getting involved. So even in hereditary neuropathy, some part of facial nerve will get involved. So some degree of facial involvement, facial weakness does occur with even axonal degeneration. But by and large, if you get facial weakness, which is either more or at least equivalent to weakness in the other muscles, we think of demyelinating neuropathies, as I explained earlier, AIDP or CIDP. Okay, the other causes include leprosy. Any other cause of monocytic multiplexer can involve facial nerve in isolation also. So leprosy, Lyme disease, and sarcoidosis. Others are now rare. So in bilateral seventh nerve palsy or unilateral seventh nerve palsy, think of these disorders. If it is a predominant upper limb involvement, that is more than lower limb involvement, again, we will think of demyelinating neuropathies or mononeuritis multiplexer. So etiology will be same, Guillain-Barré syndrome, chronic inflammatory demyelinating neuropathy. See, the dictum during MBBS training was very clear. All neuropathies are distal except Guillain-Barré syndrome. Okay, but all the causes of multiple mononeuropathy or mononeuritis multiplexa, vasculitic, leprosy, though it is rare, they can also present with dominant facial weakness. And one particular form of amyloid neuropathy known to present with carpal tunnel syndrome and a lead neuropathy is known to present with wrist drop. These are Bruton's line, one of the patients with lead neuropathy, bluish gray lines on the gums, and a wrist drop in the same patient. If you get dominant proximal weakness, that is again, think of demyelinating neuropathies like AIDP, CIDP, paraproteinemia, or sarcoidosis. If multifocal weakness means there is weakness, it can be distal, it can be proximal, but on examination, you will be able to find that the weakness in the distribution of median nerve is more than the weakness in the distribution of the ulnar nerve, or vice versa. That is, weakness is more in the distribution of ulnar nerve than in median nerve, meaning abductor disti minimi is quite weak. First dorsal interosseous is quite weak, but abductor pollicis brevis is relatively preserved. So though they just look like polyneuropathies, they are actually different from polyneuropathies because there is some evidence of multifocality in these patients. So the common causes include vasculitis, if it's a multifocal neuropathy, like polyarteritis nodosa, SLE, Sjogren syndrome, sarcoidosis again, leprosy. Diabetes can present with multifocal mononeuropathy, and two variants of demyelinating neuropathy, MATSAM and multifocal motor neuropathy. And once we come across our classic pattern of distal symmetrical sensory motor polyneuropathies, every possible etiology, metabolic commonest pattern seen in clinical practice, diabetes alone will be good enough to cover all other causes. Diabetes, hypothyroidism, acromegaly, nutritional disorders, vitamin B12, alcoholism, thiamine deficiency, critical illness, polyneuropathies, even connective tissue disorders, all what we have discussed so far, systemic lupus erythematosus, polyarteritis nodosa, all can present with confluent distal symmetrical sensory motor neuropathies. Heavy metals, toxins, amyloidosis, all can, and even most classic hereditary neuropathies, all can present with distal symmetrical sensory motor neuropathy. So we finished topography. The carry home message for topography will be dominant proximal weakness, think of demyelinating. Dominant distal weakness, think of axon. Clear? Next, and very important is, based on history, we have to decide whether, history and examination of course, whether we are dealing with a demyelinating neuropathy or an axonal neuropathy. So see, we already did the fibers. So we have grossly we have 3 or 4 kind of fibers in peripheral nerves. Motor, sensory can further divided into large well demyelinated, which carry sensations of proprioception or joint vision for that matter, and sense of perception. And small, poorly myelinated or unmyelinated sensory, and then autonomic. Clear? So, predominant motor neuropathies, I think all of you have seen in the emergency. Guillain-Barré syndrome is dominantly motor. That is, weakness is always out of proportion to the sensory symptoms, though practically always out of proportion to the sensory symptoms, and its differentials, which include diphtheria, porphyria, lead, dapsone, all come in that category. Remember that hypoglycemia can also produce, but it is, your weakness is dominantly motor. In the acute stages, at least, it is quite painful as well. So then we go to, I'm skipping this, predominantly sensory neuropathy. So all the causes which we discussed in axonal degeneration, Glavin stocking pattern, they all can present with predominantly sensory neuropathy. They can be diabetes, leprosy, you all know, is dominantly sensory, alcoholics, vitamin deficiencies, pernicious anemia, even toxins, and all paraproteinemia, they all can very well present with predominantly sensory neuropathy. So if it is a predominant sensory neuropathy, we further have to classify it whether it is large fiber neuropathy or small fiber neuropathy. So small fibers we already discussed carry this pain and temperature fibers. So what these patients will present as? They will present either as severe burning dysesthesia, they can, means that is positive symptom, severe burning, or they can present with loss of pain and temperature. That is, they come with complaint that there are burn of the finger and they are not aware of it, as we classically see in leprosy. They can come with non-healing wounds, and they may specifically, when you ask, they can tell, I cannot feel temperature or pain. So painful neuropathies are usually vasculitic. Sorry. Amyloidotic means small fiber neuropathies, classically vasculitic. Toxin and drugs, in my experience, most of these patients turn out to be toxin and drugs or vasculitis. Rarely, diabetes can also present with a painful, severely painful small fiber neuropathy. Most of the drugs, most commonly drugs I'm seeing in clinical practice now are linezolid and metronidazole. And these are the causes: leprosy, diabetes, alcohol, amyloidosis dominantly, which can present with negative symptoms, sensory negative symptoms like I cannot feel temperature, pain, and they present with non-healing wounds or burn over fingers. So this is regarding small fiber neuropathies, wherein primary damage is to unmyelinated type C fibers. And this, when the primary damage is to large fibers, the fibers which carry sensation of proprioception. Their patient usually present with that during the daytime, I am better, but in night, I cannot walk, because during dark, we are taking off the visual cues. They cannot see the place, their joint vision is gone, so they will not be able to walk. Similarly, while washing face, they tend to fall because of sensory ataxia. They can have chorioathetosis and present with piano-like fingers They commonly complain that their feet and hands seem as if they are wrapped in cotton wool, or they feel as if they are walking on sand. The common causes of large fiber sensory dominant neuropathies are vitamin B12 deficiency, Sjogren syndrome, and IgM paraproteinemia. So then a whole lot of group comes. The third one, that neuropathies with autonomic involvement. If there is dominant autonomic involvement, always think of amyloidosis and acute pain dysautonomia. Though rarely toxins like arsenic, vincristine, and diabetes can also present with this. In diabetes, usually symptoms correlate. They will be having neuropathy, retinopathy, nephropathy, along with autonomic neuropathy. These can present purely with severe autonomic dysfunction, especially acute pain dysautonomia and amyloidosis. Of course, there is a whole list, but these are the common causes which I have marked in brown. So then we have already discussed temporal profile, topography, and type of fibers involved. Next, we go to pathology. Pathology means, so we have decided it's a large fiber neuropathy, it is a small fiber neuropathy, or what? Now we have to decide if there is a damage to large fiber, is myelin getting involved, or is damage to axon. If there is a damage to small fibers, is myelin getting that? Anyhow, small fibers will invariably be non-myelinated fibers also. Damage will be axonal only. So in demyelinating neuropathy, see, primary pathology is in myelin sheath. Okay. Axons are intact or they will degenerate later. So accordingly, what we get is these fibers, A alpha and gamma, which are motor to muscle spindles, and proprioception and somatic motor will get affected. So what we are going to see is weakness will be out of proportion to atrophy. Why? Because muscles are still getting innervated by axons. So they are getting their trophy factor. So atrophy is not that much. Weakness is out of proportion to the degree of atrophy. DTRs are again absent out of proportion to the degree of weakness. The power may still be 4 or maybe 4 plus or even 5, but DTRs will be absent because these gamma fibers, which are motor to muscle spindles, are damaged. The pain and temperature, which are supplied by type C fiber, are relatively preserved, and there will be sensory ataxia and proximal. Okay. For the predominant demyelinating neuropathies, we have already done GBS, CIDP, diabetic lumbosacral radiculoplexopathies, and IgM paraproteinemia. Second is axonal neuropathy. Here, primary damage is within axon. So we are going to get weakness and atrophy will be proportional to the weakness. Similarly, deep tendon reflexes will be absent in axonal also, but they are proportionate. Once power is decreased to less than 3, by virtue of muscle itself, deep tendon reflexes may be absent. But it is not like the power is 5 and deep tendon reflexes absent. That takes us towards large fiber. Okay, sensory will be glove and stocking pattern. Distal weakness will be more than proximal, and there will be pain and temperature loss. So based on this, because small fibers or axonal damage, we get more of these features. Proportionate reflex loss, distal weakness with atrophy, distal more than proximal weakness. So at the end, I'm skipping these for lack of time. We should be able to give our descriptive diagnosis in these terms: temporal profile, topography, type of fiber, pathology, and etiology. So the diagnosis will be, say, subacute, topography, distal symmetrical, type of fibers, both large as well as small fibers, means there is motor weakness also. There may be sensory ataxia, and there is some loss of pain and temperature also. Pathology is predominantly demyelinating, okay, and etiology is query idiopathy, because I did not get any clues on general physical examination. Okay, so this all 5 things if we are able to give at the end of our examination, we are very close to etiology. So once we have done this much, now we go to the next step, that we need to have a diagnosis. Thus, just giving a patient this big diagnosis is not going to help him. So we need to find the etiology and we need to treat that. So what are the steps? So as we discussed already, so first we ascertain that yes, there is a problem. There is a problem. Second, we ascertain what is the anatomic localization. There's 2 we have already done. Next step we will discuss now: appropriate investigation, establish pathology, and then draw management strategies. Okay. Before I go ahead, I just give some tips for examination. All of you are doing neurological examination day and night, but I see in my clinical practice, but most of the time postgraduate students miss. I'm just highlighting on that. Okay, this all of you know motor. Everybody will come with proper history, that difficulty in holding chappals, getting up. I'm not. Orthostatic, always evaluate, take history of bladder and blood pressure in detail. I'm skipping this also. Now, what students most of the time they miss are thickened nerves. Always look for thickened nerves. They may be the only clue to a hereditary neuropathy or CIDP or much more common, leprosy. Okay, look for loss of eyebrows. Look for flattened bridge of nose. Look for subtle hypoanesthetic patches, which may give us to the clue of the etiology. Look for foot deformity, for example, pes cavus. Always look for kyphoscoliosis. Look for other stigmata, curly hair, pigmented nevi. Look for trophic changes in the feet. Always try family history and always evaluate fifth nerve. I commonly see they would have done a fantastic neurological examination, but would not have checked for kyphoscoliosis, pes cavus, and they will never come after evaluating trigeminal nerve. Remember, if in a patient with generalized neuropathy, there are perioral numbness and paresthesia, the most likely diagnosis is either Sjogren or a perineoplastic, which is relatively easily treatable. Of course, for rare patients, general physical examination should always be complete. In large spleen, yellow orange tensils, point to 10 years. I just skipped that. Angiokeratomas, point towards diagnosis of Fabry's disease. Another thing, many of the time, patient says I'm having trouble, but on routine examination, you don't find any weakness. So please remember that do functional assessment in there. Ask the patient to walk on toes. Ask the patient to walk on heels. Ask the patient to sit on chair and get up from it. And ask the patient to do a deep knee bend. Okay, deep knee bend. To stand on both legs or one leg and then bend on. They will bring out very minimal weakness. Clear? And always remember that grip strength is not a tool for distal muscles. There is no role of distal muscles, distal hand muscles in grip strength. Distal hand muscles, first dorsal interosseous, abductor pollicis divarus, adductor distal minimi, interossei, have no role in grip. Grip is a function of forearm flexors, which are in the category of intermediate muscles. So never use grip as a screening tool for distal muscle strength. Check FDI, first dorsal interosseous and abductor pollicis divarus. For sensory, always compare symmetrical areas on two sides of the body, compare distal and proximal areas, and map out area of sensory loss. If sometime we are not able to take help of patient, tell him to draw the area where he is not able to. In case of lateral cutaneous nerve of the thigh, most of the time patient draw a better map than attending physician. So I skipped that. Right, so these were some of the points which you need to highlight while doing examination, which should not be forgot. So once we have done examination history and we are very sure that I am dealing with a, say, chronic sensory motor, distal more than proximal, axonal, multifocal mononeuropathy. So now what I need to do? So first is, now we are going to evaluate. How we are going to evaluate? First is laboratory test. So depending upon the cause, if a patient is suspecting from diabetes, of 20 years duration, there is retinopathy, there is nephropathy, and he has mild sensory-motor polyneuropathy. I don't think we need to do anything else other than maybe do just beta vitamin levels and advise him to continue management of diabetes. On the other hand, if we are not able to find out the exact cause, we have to do detailed testing, including vasculitic workup, serum immunoelectrophoresis. Of course, it will vary from patient to patient. Urine analysis for bench-on proteins, even to the tune of heavy metal screening. As more and more of our population is getting addicted to drugs, we may need to do CSF to look for albuminocytological dissociation. We may have to do Lyme serology, and we may have to do markers for systemic malignancy. In our institute, currently, in tertiary care institutes, we often receive difficult to treat neuropathy. So for systemic diseases and malignancy, almost all of the patients with undiagnosed neuropathy end up in doing a whole body FDG PET. So these are some of the hypersegmented neutrophils, as you see, is vitamin B12 deficiency. This is punched out lesions with osteosclerotic lesion in the spine and a M component, as we see in Poin syndrome. So once we have evaluated the patient, suppose we get ANA positive, dsDNA positive, we know we are dealing with a vasculitis and all that. The next test is to do nerve conduction study. Here the aim of nerve conduction studies. See, the most important thing while ordering nerve conduction studies, the most important thing is nerve conduction studies are nothing more than and extension of the clinical examination. They do not provide anything more to us. Okay, so it has to be always provided in the in the light of clinical examination. What it helps primarily is for detection of subclinical changes. It helps us in quantification, and it helps us in comparison of finding as disease evolves or resolves over time. See, many times you make a clinical diagnosis of peripheral neuropathy, but nerve conduction studies are absolutely normal. Please think at that time that I may be missing a pseudo-neuropathy presentation of a myelopathy. Okay, these are well known. Everything, none of us can make diagnosis correct all the time. That investigations are done to make sure that we do not miss anything. So nerve conduction study is basic, and see clinical examination and then correlate nerve conduction studies with subclinical change. The purpose of performing nerve conduction studies with most of the patient is to first find whether they are normal, and then they can tell us whether the primary disease process is demyelinating or axonal based on primarily in demyelination. See, myelin sheath is getting damaged. So what we are going to see is prolongation of nerve conduction velocities. Okay, so we will see nerve conduction velocities prolonged, distal latency. These are all markers of nerve conduction velocity only. So conduction velocity will be decreased while CMAP amplitude will be relatively normal. It is not absolutely normal, relatively normal. Okay. While in axonal neuropathies, myelin is preserved. It is primarily the axons which are getting damaged. So conduction velocity is usually mildly reduced, while CMAP amplitudes will be much more reduced than. So that is the main purpose of doing conductions, to differentiate between demyelination versus axonal. Okay, I'm not going through details of that. We have specific tests to detect small fiber neuropathy also, which we commonly do in our labs. Next is nerve biopsy. If I am not able to get diagnosis, not certain about the etiology at the end of my clinical and laboratory and nerve conduction studies, we may have to go with nerve biopsy. Try to get the nerve which is affected, and always do it in the light of clinical examination, which nerve you are going to choose. If a person is having bad foot, okay, there are ulcers, there are other things, one should try to avoid sural if possible, because that does not heal. In that patients, we can choose dorsal cutaneous branch of ulnar nerve, or for that matter, superficial peroneal nerve. So the choice of nerve will vary from patient to patient, right? And as expected, nerve biopsy is not without any, clinical, without any side effects. There can be delayed wound healing, wound infection, and some other, rarely neuroma formation also. These are some of the representative. You can see slides for nerve biopsy, Hansen's. You can all, I think, can see acid for fast bacilli. This is, you can see here, inflammatory demyelination, very few fibers. There is loss of myelinated fibers. There are clusters of inflammatory cells. You can see onion ball formation in demyelinating neuropathies. And you can see giant axonal formation in giant axonal neuropathy. Usually, biopsies provide us diagnosis in more than 70% of patients, but if still the diagnosis, we don't discuss that. So once we have done all the investigations, we have reached at a conclusion. So what? So final step, which is going to benefit the patient, is treatment of neuropathy. So one is specific treatment etiology based. Your index patient turns out to be having vasculitis, treat it. Your index patient is having leprosy, treat it. Okay, your index patient is having acute inflammatory or chronic inflammatory demyelinating neuropathy, depending upon the affordability, availability of drugs, use IVIG, depending upon the severity, very severe, use plasma exchange, or use steroids and alternative immunosuppression. And if disability is primarily because of pain and we are not able to find any cause like diabetic painful neuropathy, then we provide symptomatic treatment. So as I discussed, we can give corticosteroid, we can give immunosuppressants. Our institute now, we are using for severe neuropathies, drug of choice are either cyclophosphamide or rituximab. Rituximab is being used much more commonly. Plasmapheresis, intravenous IV, immunoglobulin, everything can be depending upon the patient profile. And I'm skipping these. Depending upon the etiology, you can treat accordingly. For entrapment neuropathies, of course, surgeries. And for pain, if there are severe disease areas, can try amitriptyline, carbamazepine, gabapentin, maxilitine. I usually use carbamazepine first, followed by gabapentin, just for the simple reason of cost. But all these drugs are probably equally effective. So I think we end our talk here. For lack of time, I am skipping the other slides, and I hope there will be a lot of questions, and I also will learn something from you. Thanks a lot for patient hearing. Thanks.
Sir, for such an interesting session. There were a lot of pictures and which can stimulate the participants for the learning, and also there were case-based learning. So that was indeed a wonderful presentation, sir. Sir, before I read questions from the participants, I also encourage the participants to write down their queries, their doubts in the chat box. So, sir, a small doubt from my side. Like you mentioned the various causes of neuropathy. So, is there any trend shift of these neuropathy causes cause wise? Since earlier, I think infections were the most common cause, or maybe now the metabolic, or maybe the paraneoplastic, or maybe the uh, autoimmune causes are leading. Matlab, is there any trend shift?
Yeah, definitely. Idiopathic
Sir,
inflammatory are much more common. Paraneoplastic are much more common. But
sir.
I really do not see leprosy has definitely decreased. There is no question of that.
Right,
Okay,
sir.
no question of that. But whether the other neuropathies we were not picking up earlier and now we are picking up more is a matter of
Right, sir.
debate. Is a matter of
Yeah.
debate. But leprosy has definitely decreased. But it is not disappeared. We keep on
Right, sir.
seeing.
Right, sir. Right, sir. Sir, there is a question asked by Dr. Rajni on YouTube, sir. The classification that you mentioned on the basis of onset, so that was duration wise. So acute, subacute, and chronic. So it was like 4 weeks, and then I think it was
I
1 month.
mentioned 8 weeks.
Yes, sir.
Some books mentioned up to 6 months also.
Sir. So it is like, is this, they she's asking that is this the same for all the neurological disorders, or like it's mainly for neuropathy and different for different neurological conditions?
It is practically for neuropathy. See, for neuroinfections, acute is 1 to 7 days, subacute is after 1 week to 4 weeks. It basically the only difference for different disorders is, see, the only difference here is if it goes beyond 4 weeks, I feel I have to give a longer immunomodulation rather than just one course of IVIG. This is just based on that. So it is just like Dr. Rajni, I think the name. Dr. Rajni, it is just like when we were doing degrees, FBS was 140. Today it has decreased. Then it came 120 and now it is 110 and now it will go even lower than that. So as our knowledge keeps on evolving, for all practical purposes, I have seen that if the duration onset to peak is more than 2 weeks in a case of GBS, most of the time it is not acute GBS, it is some form of subacute inflammatory demyelinating neuropathy only, but that may change. This is only for neuropathy. This definition which I used.
Right, sir. Thank you, sir. So again, I request the participants uh, to ask questions. If you are unable to type or write, you can unmute. You can just raise your hand, and we can unmute you, and then you can ask the question. Yeah, so one question is posted by Dr. Randhir Chaudhary. A 60-year-old female patient on case of Parkinson and hyperthyroidism came with progressive dementia, dysphagia, and no motor movement since 14 days. So vitals are stable, no respiratory distress. So exact, what do you want to ask, Dr. Randhir? You can also unmute yourself, or we'll unmute you. Dr. Randhir Chaudhary को आप please unmute करना. Your question, like it appears to be partial. So Dr. Randhir, you can speak now.
I really don't know. Of late, one is in such a scenario, we can consider a paraneoplastic cause. And rarely we have seen at least one or two patients where we found association of IBM with this Parkinsonism and FTD as part of that FTD symptom complex. Otherwise, you can dissociate Parkinsonism and progressive dysphagia from no motor movement and evaluate in a totally different line that they may be unrelated to the underlying disorder. So just find out. But based on this history, it will be very difficult to tell. Evaluate can dissociate the two also. There is nothing prevents a person who is having Parkinsonism and progressive dementia from having a new illness. Anti-GBM3 antibody is positive. Okay, we can treat it. No issue. We can try to treat.
Hope your query is answered, Dr. Randhir. If you are listening us, you can respond by okay.
No,
So
if our diagnosis is clear, then we have to hope
right.
and treat.
This is
The
regarding
thing is,
management, sir.
every time it is not possible in every time it is not possible every patient will improve. If we are certain anti-GM3 antibodies, we wait. We
Okay,
wait.
so I think his query is resolved, sir. Like he is thanking you. Yeah. So another query by Dr. Neeraj regarding recurrent GBS evaluation in the young patient, mainly around 20 years of age. So he needs your comments and your views regarding this.
First episode of GBS, we just
Yes,
do routine testing. We do serum electrophoresis and common causes, but other very common causes. We usually don't go ahead with the extensive vasculitic workup or PET or anything. The moment it is more than one episode, we suspect it that maybe there is an underlying cause. Of course, porphyria. Before making a patient as GBS, we have to rule out porphyria. We have to we have to look for serum potassium, ECG, and all these CPK, all that. More than 3 episodes, the chance is much higher. 3 or more than 3, chance is much higher of him having recurrence. So we give him continuous immunomodulation, thinking it is CID. This in between with only 2 episodes is still a question mark. If the gap is too less, say 6 months, 8 months, we can treat like we can give immunomodulation for a long duration, but not with certainty. Attack is mild, we can wait. Attack is very severe, both times we may have to give. So depending upon patient to patient, but if one thing is sure, 3 or more, we treat like CID.
right, sir.
Dr. Jaswant, you can also add something if I go wrong somewhere.
No, sir. You
Nobody
are
can know
expert in
everything.
this field, sir. I'm like,
Please
I'm
correct me
nowhere
if
in
anything
like
happens.
if we talk about the knowledge, sir. So fantastic, sir. So if there is any other query regarding the same, still, yeah, Dr. Tina, no, someone I think unmuted. Sorry, someone raised their hand. So we just saw the raised hand and then they put it down. So you can still raise your hand and we can unmute you and then you can ask question. Yes. So Dr. Dipashri, she is asking treatment for diabetic peripheral neuropathy with peripheral vascular disease. So how the treatment would be different, sir, here?
Treatment will
Per-
practically be same. See, at the most we can use drugs like pentoxifylline or something for peripheral vascular disease, but practically treatment will be the same. Unless and until there is very severe, we may have to restore we may have to achieve revascularization depending upon the patient. Only thing, Dr. Dipasri, I want to make a point here that diabetes is very common in the community. Very common in the community. So always think before you label as a patient with diabetic neuropathy, if my index patient is having neuropathy only because of diabetes or diabetes is just a dead herring. I have never used it, so NSRIs, so I'm not the best person to comment on that.
right, sir. Thank you, sir. Thank you, ma'am. We can still take the questions, and it would be great if we have an interactive session with the participants. Okay, so no more questions. Right. Thank you very much, sir, for such a wonderful session. Now I request Professor Ajay Kumar Sood, sir. Sir is the Deputy Secretary of National Academy of Medical Sciences for the vote of thanks. Sir, over to you. Sir.
Thank you, Dr. Jaswant. And it is again my great privilege to thank the distinguished speaker for this session, Dr. Manoj Goel, sir. Thank you, sir, for being with us and covering this topic very comprehensively and giving practical tip to all our students, especially
Thank
the
you,
PG
sir.
students. And we again grateful to you for your blessing and support to the academy. And we look forward for your support in future also, sir. Thank you so much for joining us.
Definitely.
I also take this opportunity to thank all the participants, faculty members who have joined us. And once again, I want to make an appeal that faculty members may kindly come forward and give us suggestion. And also you can act as a resource person for some of the session if you want in future. For the PG student from next year, we are going to start another interesting series on oral health. So that is the first session which we have on the first Friday of the January. We are going to cover on oral health. There it will be useful also to other PG student and especially for the dental student also. So soon we are going to circulate all the details with you. Another information for PG student is that in collaboration with the ICMR, NAMS has started a online helpline, biostatistical helpline. And this will be useful for the PG student and the young faculty who have certain questions and query related to the thesis or project work. And the experts from NAMS and ICMR, they are really happy to help you. And this is online registration as per your convenience. You can register on the portal and the experts will be happy to answer your question inquiries. So once again, I would like to thank again Dr. Jaswant, who has been with us now for nearly 2 years for helping us. And thank you so much for your support to the academy. Here in the academy, Mr. Ravi and Mr. Shivam have been helping us in organizing these programs and writing letter to you. So we appreciate their support. And once again, on behalf of the academy, I convey greetings and best wishes for the festival season, which we are having next week. Christmas, Merry Christmas and a Happy New Year. So with these words, once again, I thank you all for joining us. Namaskar. Over to you, Dr.
Thank you, sir. Thank you.
Thank you, sir. Sir, the session's compliments are, we are still receiving a lot of compliments apart from questions. So this shows the quality of session. Thank you very much, sir. So with this, with your permission,
Yes.
we can mark the closure of the session.